Hi, I am William Roth, a dermatologist from Boynton Beach, Florida, and it's my pleasure to speak on tumors of the lower extremities. I am a voluntary clinical professor at the University of Miami School of Medicine, and I've been providing radiation therapy for skin cancers since 1979. As far as disclosures, I am a consultant and serve on the advisory board of Census, and I did receive a grant in 2019 to coordinate a multi-center review. SRT is truly part of dermatology. The first patient treated with a basal cell was in 1905. Dr. McKee at what is now NYU wrote the first book on radiation therapy in 1921. And this is one of my textbooks, Sutton from 1939. And they show remarkable results treating very difficult skin cancers with radiation therapy. With superficial radiation therapy, we provide it with a fairly small movable unit with an articulating arm, with an applicator that is placed against the skin. Therapy is provided in variable doses and frequencies based on the location and features of the tumor, and protocols for this are well established. The American Cutaneous Oncology Society in 2019 published a consensus report recommending SRT as a first-line therapy for non-melanoma skin cancer, and ASTRO as well in 2020 has defined SRT as a first-line treatment. And superficial radiation therapy provides an excellent result for many skin cancers, especially in difficult areas, and it vastly reduces the risk of bleeding or infection associated with surgery. This was the standard of care, but it shed a negative attitude toward treating the lower extremities. Was this article in the Journal of the Academy of Dermatology in 2001 by Dupre. I did publish this article in the Journal of Drugs and Dermatology in 2019, where I treated 151 leg lesions with a 97% cure rate. And my 4-year follow-up was 32%, my 3-year follow-up 30%, my 2-year follow-up 20%. All of the patients do get pink, do get scaly, a little bit of crusting and ulceration. 11 patients reported itchy or painful skin. 1 patient experienced edema at or below the treatment site and was recommended to use support stockings and elevation. But all of the adverse events resolved. And I sort of insist on any of the patients that I treat that have edema, use support stockings before I start using the SRT. So for the lower extremities, I sort of like to break this into 3 groups: uncomplicated, challenging or complicated, and legs from hell, which are very challenging, very complicated. And these are affected by comorbidity and location, and the hands and fingers are also in category 2 and 3. So some of the patients that I initially treated, they're all over 65, but now my patient population has grown much older. But these people are between 65 and 70, squamous cell carcinoma in the leg, 3 fractions per week. I have treated a lot of skin cancers on the feet. This is a woman with a squamous cell carcinoma on the dorsum of the foot. I treated her with 1 fraction per week for 14 fractions. When I use 50 kV, the D to the 1/2 is about 6 millimeters, 1/4 inch. She really doesn't have 1/4 inch between her skin and the bone underneath. So some of these patients will have pain where you have to take a break. I did not have to take a break with this lady. At only 3 months afterwards, she looks great. So fractionating the dose. Fractionating the dose reduces the acute effect of radiation while improving the cosmetic effect. Tumor tissue does not recover from the damage of the radiation as well as normal tissue, and thus we selectively destroy the skin cancer. This is a challenging patient on the tibia. This was 6 months post, 2 fractions per week for 14 fractions, and it's right over the tibia, very thin skin. And I just want to emphasize you frequently have to take breaks when you're treating these patients. This was one of my legs from hell. I really didn't want to treat this patient, but she complained that it was hurting her. She actually had a Merkel cell. This is on her left lower leg. In her right groin, she had a node that was positive for Merkel cell carcinoma, and I felt she's probably not going to be alive. But because it was hurting her and her primary care doctor wanted me to treat it, despite severe edema, I gave her 1 fraction per week for 14 weeks, uneventful. 1 month post, she had all the scaling around the lesion, and she lived with the Merkel cell. This is a picture 1 year afterwards. This is a large squamous cell, poorly defined area. If any patient should have a recurrence and difficulty with the radiation, I would think this lady would have it. Severe actinic damage, stasis dermatitis, no problems at all, healed well, no complaints, no breaks. It's difficult to predict which people have problems. Another challenging case, a basal cell carcinoma of the foot, which was quite large. My port was 2.4 by 2.5 centimeters. I gave him 14 fractions, 1 fraction per week, had to take a 2-week break during the treatment. This is 4.5 years after treating him with SRT, and I maintain that this is an amazing result that would be difficult to match with surgery. I was referred this patient with a squamous cell carcinoma on her second toe. And I treated her with 1 fraction per week for 14 fractions with no difficulties. And at the end of the course, she has the red nail polish. 3 months later, she has the bluish nail polish, and it healed where you can't even find where she had the skin cancer. Another lady, 90 years old, Eloquis, anticoagulation, stasis dermatitis, edema, a history of severe cellulitis. I gave her 1 fraction per week for 14 fractions, no difficulties, no breaks in therapy. The skin cancer went away. So I'm just bringing this out because it's not that easy to predict which people have problems. This lady had an ulcerated lesion. This is before I started. I consider these deeper lesions. She was 95. I treated her with 70 kV, 14 fractions. She did very well. This next patient, at the start, another 95-year-old. My average patient now is 85, but I want you to look for pain as an indicator for resistant tumors. I've had several patients, 3 or 4 patients since 2011 that I felt did not respond to SRT. And I do think it was due to poor circulation. One lady, when I had her come back, I was going to do surgery on her. She told me she was having bypass surgery to her leg. But when the person starts out with a lot of pain and it's really hurting them, I would look for circulatory problems. I recently saw this patient. He had severe stasis dermatitis, horrible legs, and these very large lesions were squamous cell carcinomas. And I was torn between the problem of how big a margin to leave. These were well-differentiated squamous cells. As you make a larger port, there's a volume effect and you get much more damage to the skin. But I treated them with approximately the margins that you see, which is only about 5 or 6 millimeters. And his legs are completely clear now. But this is another patient that you really wouldn't want to do Mohs on. You'd spend months having them heal. I have had a few patients that got leg ulcers remotely, meaning as far as 6 months after the SRT. The one which is most familiar to me is a lady that went back up north for the summer. She developed severe congestive heart failure. Her legs blew up. When she came back down, I treated her with support stockings and wound care, and it took about 4 months to heal. You can see the quality of her skin after it's healed, which is very poor. But it is possible to get these patients to clear, but you have to be on the lookout for people that get severe edema. So where do we want to use SRT? We want to use it where it's difficult areas for surgery, areas that are likely to scar or deform, like the nose and ears, patients where other modalities present challenges, and where it's the patient preference. This is from Cognetta's book. With SRT, we must manage the comorbidities. We must manage the edema. Edema, as I mentioned, months later can cause problems. We must treat the dermatitis, and we must look for circulatory problems and take breaks for pain. With support stockings, patients will sometimes give you a hard time. There are these support stockings with Velcro, which are more expensive but very easy to use. So in closing, I'd like to say that SRT allows each of you to make a significant difference and improve patient care. For the type of lesions that we see in our practice, we can provide care better than radiation oncologists. It's our responsibility to provide the best possible care for our patients, and the art of SRT belongs to dermatology. And now it's time to fish, and I'd like to thank you for this opportunity to present some of my experiences with SRT. Thank you.